We've got a little video clip of her shoulder arthroscopy. On this, you'll see that when we introduce the arthroscope, it's immediately apparent the extent of her injury. She has an extensive posterior labrum tear. She has the slap lesion. Her shoulder volume is very large. The humeral head will distract away from the glenoid, and there's just a lot of space there. It's a patulous capsule. And this all needed to be, the labrum needed to be repaired, and her capsule tightened and restore stability to her shoulder. So you'll see that once we identify the injury, we go in there and abrade the bone. You want to just lightly scuff the bone and decorticate it a little bit just to get some bleeding bone there that will accept the new labrum and will repair the labrum. We're going to be putting in suture anchors and sutures and holding this in place, but that's not the permanent fixation. That simply holds the labrum in proper position until her body can heal that. And I always say the tissue has to put down deep roots into the bone so that it gets a good firm hold, and then you rehab the shoulder and strengthen the shoulder and restore a more normal shoulder. But you'll see us identifying the tear, abrading the bone, preparing it to accept the anchors, placing suture anchors, tying the sutures, repairing the posterior labrum, then repairing the superior labrum. Then we go over here to the rotator interval and close that rotator interval again. That will tighten the capsule and reduce that redundancy, that patulous capsule, and that too much volume in there. And you want to tighten it to just the right amount so that she's still going to have a good range of motion and a very functional shoulder, but without the pain and apprehension that she's had. All right, here we've introduced the arthroscope, and you immediately see that slap lesion, the superior labrum tear. The humeral head is above, the glenoid is below, but she has an extensive slap lesion. The labrum is draped down over the top of the glenoid. Now moving more inferiorly, you can see the posterior labrum tear right up against the camera. Now we're going to move anteriorly. I'm introducing a blunt obturator, or a switching stick as we call it. And over this, I will pass a cannula. These plastic cannulas kind of hold your place in the soft tissue and establish a working portal so that you can introduce and remove instruments easily without damaging the soft tissues by repetitive passes. And here you see the cannula coming in. It's threaded so that it just screws right into the soft tissues. Here I've introduced a shaver, and I'm pulling the biceps tendon down out of the way. The biceps tendon is normal, but you see behind the biceps tendon is the rotator interval between the subscapularis and the supraspinatus. And you can see how that tissue has a stretched, injured, scarred appearance. That is the stretched rotator interval, and we're going to need to close that. You can see now that the humeral head's being distracted away from the glenoid. There was too much space there. It was too loose. Now we're looking at the posterior labrum. Again, there's a very extensive posterior labrum tear all along the back of the socket. Now I've introduced a hook probe, and I'm probing the posterior labrum tear, and you can see it's totally detached from the socket or the glenoid. There we are at the 6 o'clock, coming back up to about the 2 o'clock position and entering the slap lesion up around 12 o'clock. There's the anterior labrum, the only part of her labrum that's still attached. And the anterior branch of the inferior glenohumeral ligament is still attached. Now at this point we're introducing a needle. This will guide the placement of an additional cannula. And you can see a knife blade coming in alongside the needle. It's just a safe way of accessing the joint, not damaging any structures by introducing the cannula. And now we're inserting another screw-in threaded cannula, again to allow safe passage of instruments. Now here we are inspecting the slap lesion and introducing a shaver. We're going to pull the lesion up out of the way with this hook, and that will allow me to place the shaver against the extra-articular bone, meaning not the joint surface, but the bone at the superior glenoid or the top of the socket. And I'm going to lightly abrade that bone. And what you want to do is remove a little bit the top layer of bone and get back to bleeding bone. That bleeding bone brings in healthy cells that will bond to the labrum when you repair it, so that it will put down deep roots in the bone and anchor and heal itself nicely to the bone. Again, we're probing the posterior labrum here, getting that out of the way and preparing an opening that we can introduce the shaver. And again, we're using this shaver with teeth to lightly abrade and remove the upper surface of the bone to get some bleeding bone in there. And now we're using a slightly different shaver, bigger shaver without teeth, and we're abrading the bone again. And that's bone debris and bone dust and particles flying around, and we periodically through the procedure evacuate that bone dust so we don't leave all that debris in her shoulder joint. As you can see that we're preparing a bed there that the anchor will knit back together nicely with. Now we're using our third cannula, the posterior cannula, and introducing a shaver again. Each cannula allows me to address about 3 hours worth of the clock face, if that makes sense. So now I'm addressing the clock face from 3 o'clock down to 6 o'clock through this posterior cannula. The superior cannula let me get from 12 to 3, and the anterior cannula got the remainder. And you can see we're removing all that particulate debris. Now we're introducing a rasp, and this is a metal device that has sharp teeth on it that we can place against the bone, again, just to abrade the bone and stimulate a healing response. I want to be sure that labrum bonds very solidly and securely to the bone. The sutures simply hold it in place during the healing process and the healing period. Now I've gone back around to the superior cannula that allows me to get from the 12 o'clock to the 3 o'clock position, and again abrading the bone, preparing the bone for good healing. And finally, with the rasp in the anterior cannula, I can abrade the bone directly beneath the slap lesion, preparing the bone in that area to accept the labral repair. Now I'm introducing a grasper, and I'm grasping the posterior labrum near the top of the labrum, and I'm pulling it superiorly, pulling it up and applying tension. That's going to put it in the position I want to shift it superiorly. And I'm introducing this suture passer that will allow me to shuttle the suture. I'm trying to get a good, generous grasp of the inferior capsule. I decided to get a little bit more capsule, a little more inferiorly at the 6 o'clock position, and bunch up that capsule a little bit. We call that imbrication of the capsule or plication. I want to tighten that capsule a little bit so we can tighten her joint without over tightening and limiting her range of motion. And now the shuttle is being deployed, and I'm pulling the suture back, and this allows the final suture to be placed. Now I'm grabbing the anterior branch of that suture and pulling it out the back, and you can see the extent of the labrum tear there. So now I have the suture coming out the back, and it's preparing the labrum down around the 6 o'clock position and going to shift it superiorly. This is introducing an awl which will guide placement of the tunnel. The process here is to create a tunnel into the bone and then load the suture into a suture anchor, a plastic device made of a material called PEEK, which is a high-density polymer. And the suture anchor will be pounded into this tunnel that is created and secure the labrum in place. Now you can see the metal drill spinning. There's bone debris flying out into the joint, and I'm meticulous about removing that bone debris as the surgery proceeds. I don't like to leave a lot of bone dust and bone particles. It's kind of gritty and sandy, and I like to get that out of the joint. So now we're simply evacuating all that bone debris. Well, some of the bone debris is in a recess along the anterior shoulder, so I'm going along there and getting all that out of there. And I like to do that just periodically, kind of clean house as I proceed. Now we're introducing the suture anchor. And I'm pulling on the suture as I introduce this anchor, and I'm inserting the anchor into the tunnel. This is the guide that the anchor will slide across. And coming into view now is the anchor itself, made of that PEEK material. This is going to be pounded into place. You can see it jump as the mallet is hitting it, and this is pounding it into the bone, and it's reverse threaded so that it cannot back out. And we remove the guide. Now we put a suture cutter in there and cut the excess suture, and that secures the most inferior labrum. Now we just need to repeat this with several more anchors. We're drilling for a more superior anchor. Again, we're at about the 2 o'clock position here along the posterior labrum, and creating bone debris and preparing a tunnel for the next anchor. And here is the second anchor being inserted into the tunnel. And again, we'll strike the anchor with the mallet, and that will pound it into place. Notice the anchors are placed up on the face of the glenoid a little bit. We use an offset guide. Now we've placed a third anchor already in the slap lesion at about the 10 or 11 o'clock position. And I'm looking at the tunnel here for a fourth anchor that's going to go in about the 1 o'clock position. And the suture is already passed. Now the anchor is being inserted, and you can see that anterior anchor with a little blood coming out of the anchor tunnel. This fourth anchor is being pounded into place. 1:30 position, securing the posterior half of that slap lesion. So we've already secured the posterior labrum, and we secured the front of the slap lesion. Now we're securing the posterior aspect of the slap lesion. And now you can see we're probing the slap lesion. It's well fixed. There's one suture anterior to the biceps tendon, one suture posterior to the biceps tendon, and it's well fixed back to that abraded bone that was prepared carefully so that it will heal. And now we're introducing the shaver. You can see that the humeral head still can be distracted away from the socket, the glenoid. We want to tighten that up, but I'm just removing some bone debris, but that shows the distractibility. We're introducing a radiofrequency probe, and we're going to do a limited amount of shrinkage. By introducing some heat to the capsule here, it will contract those collagen fibers and shrink the tissue. And notice we're leaving a band of healthy tissue between each stripe of treated tissue. But you can see how that is tensioning those ligaments and tensioning the capsule and reducing the redundancy and the stretch that she's experienced in her capsule. And the tissue is responding nicely there. Now we've passed sutures across the rotator interval, and we're pulling those sutures together and tightening that. We saw at the outset of the video, the rotator interval is stretched, and by pulling these together and tying those sutures, we can really reduce that volume in the rotator interval, which is up at the top of the shoulder. But by pulling that up, it's like pulling a purse string. It will tighten up the bottom of the shoulder as well, the inferior aspect. And now you can see the biceps tendon that I'm probing there and the rotator interval behind it, and it's a much tighter, less redundant, less voluminous capsule. I'm pulling that biceps out of the way, and you can see the rotator interval behind it, which has been closed nicely. And now you can see when we strike the humeral head, it's much more appropriately positioned relative to the glenoid. It does not pull off of the glenoid as far. A much more stable shoulder.